these materials out with afterwards. Super, and we've just turned on the recording so that we can make this available to those that weren't able to attend. Because you all are so good. You've logged on early, and here I'm already in hopes that you can co-process, and I'm already telling you what to do, but you're hopefully putting your name and organization isn't too hard. Alexis, great to have you with us today. Emily, nice to see you. Morgan. Shout out to Chemonics for joining. It's great. We'll probably start at 3 past, so you're 3 minutes past the hour. So welcome to keep co-processing while you do things. Once you've put your name in the chat and your name, organization, and project, welcome, Kiyosh. Welcome everyone that's just joined on. We'll start the meeting in just another 2 minutes, but if you can take the time to put your name and organization and program in the chat, that'll let us know who's on the line to communicate with. And you can also familiarize yourself, if you're not already, with the way in which we've shared the visuals, the slide deck for today. It should allow you to move through the slides yourself, to toggle through the slides, but then to click on sync back to the live presentation so you know which slide everyone else is looking at. So it gives you a bit of control to see what's up next, or if you want to go back, you can toggle back and forth, and then it'll give you an option to live sync to what Liz Pena, who's on the line with us, is showing, sharing on the screen. Welcome, Stephanie. Great to have you and your team here. Welcome, Rebecca. Nice to see you, and Megan. This is a great group. Well, with that, I might kick things off. So I'm Cynthia Eldridge. I'm the project director from FHM Engage, and I'm going to work alongside Andrea Baer today to facilitate this discussion. You can just toggle to the next slide if you want, Liz. And Happy New Year. I think we're still allowed to say that. It's the end of January. We'll get one last meeting in, and it's great to reconnect with you all since October, where we had the presentation from the Integrate E program and Society for Family Health in Nigeria. And we've taken to some time as a program to sort of recollect and keep that focus on Nigeria, but we're going to pilot out a different approach today, a way of being more inclusive and more responsive to the feedback from the community of practice that we heard from you all in July about wanting to understand, wanting to be able to explore the markets and understand the tools and the approaches and the research that are being used currently to understand and address those markets. So we have a different approach today that we hope will work for you all, and will guide you through it. It's a gentle reminder, though, for you upfront, before, which is that a community practice is one where you get out of it what you put into it. So we're going to give you lots of opportunity and call on you all today to be really active in the chat. Let us know what you're interested in, what's working for you, what questions you have, and we will work to be responsive to that in the subsequent sessions. So I'm going to hand it off to Kuyosh, one of our co-chairs, Kuyosh Kadyrov from USAID, just to provide a bit of an overview and introduction. Thanks, Kuyosh. Next slide, please.
We can't hear you, Kuyosh.
You can go to the next slide. Okay. Well, while we're waiting for Kuyosh to work out his voice, we can go back one slide, and I'll just say, sorry, because I went a bit fast. Liz, if you want to try it. And we're going to hear from Ben and Kuyosh, and then we're going to hear from Chris Jones to do an overview of framing up this market development approach and really understanding how it helps us to understand these markets. We're going to provide a bit of a context on the market that we're talking about today, the family planning and markets in Nigeria. Solina is going to join us for that. And then we have rapid summaries that go into tools and approaches and research and programs. We've got about 10 of them lined up today. And then Andrea Bear will help facilitate a discussion. We'll leave some room for a question and answer from you all, and thinking about what next for this community of practice for next month. Is it working now, Kuyosh?
Can you hear me now?
Yes, it is. There you go.
All right, great. I apologize for that. Welcome, everyone. My name is Kuyosh Kadyrov. I'm with the private sector team in the Office of Population and Reproductive Health, USAID, and I'm delighted to kick off our inaugural session of the new Healthy Markets Community of Practice. Thank you to UNFPA as our co-chair, and thank you also to my team, Andre Bear and FHM colleagues, Cynthia and Elizabeth for organizing, and to our many colleagues from Nigeria and also global partners for contributing to today's event. Today's session is an exciting kickoff to our new format as we evolve from the Total Market Approaches Technical Working Group to Healthy Markets Community of Practice. While we will stay focused on family planning and reproductive health markets, we are setting a new direction to focus more explicitly on local market development and local private sector engagement approaches. Our shared goal is to really working to develop healthy markets that are responsive, equitable, resilient, driven by consumer needs, and more importantly, led by local actors. And so to that end, we really wanted to shift the format to a more of a meeting place and community of practice for sharing through a monthly single country focused, but also engaged and multiple speaker format, so we can really facilitate broader sharing from many country-based partners and actors. And this approach is very much consistent with how we want to innovate on developing family planning markets, which is making sure that we invest in understanding how markets work before we intervene, and working with and through local partners and market actors. And so our objective for today, as it will be for future months, is to really generate greater awareness of family planning, market development, and private sector engagement approaches, that the work that you all are doing in many countries. Today, of course, we will learn about Nigeria, and I trust that we all leave with much greater understanding and also appreciation of the market development work that you all are doing in Nigeria. We hope that Healthy Markets Community of Practice will create opportunities to build on each other's learnings, collaborate and generate new ideas, address some of the gaps, but also inform some of our donor priorities and potential market investments. And so for those of you who are speaking today on your organization's work in Nigeria's family planning market, thank you so much for agreeing to share and to try out our new engagement format with us. And for those of you who are listening, I hope that you will be active listeners. Please share your thoughts and ideas in the chat, and more importantly, enjoy learning about Nigeria's family planning market. We hope that we will announce an advanced schedule of countries to facilitate more learning about the markets, and we welcome everyone's input. We also welcome your inputs on the format of today's session and how we want to evolve over time as a community of practice. And so thank you again. And before we jump into learning about Nigeria's family planning market, we are excited to have Chris Jones with us, who will help set the stage with the market development approach. And so thank you, Chris, for your contribution.
Thank you, Koyash and Ben, for inviting me to share my experiences and giving me this daunting task, or somewhat daunting task, of setting the stage for presentations of some really great work that's happening today in Nigeria. It occurred to me, Koyash, in preparing for this, that we've now worked together for, I think, in shape or form for 25 years, which makes us both quite old. I work with Man Global Health, and I'm also supporting the FHM team in designing their approach to an MDA and country-specific analysis. Just for some context, I'm a former social marketer and lived and worked in Asia and Africa, and I've spent the last 7 or 8 years trying to think through how we can apply a market development approach to health markets. Still learning every day. I wanted to start by not diving into the depths of a PowerPoint presentation right away, but sharing a recent aha moment I had. I get to live in the Pacific Northwest, which is a corner of the US with lots of mountains. And last weekend, my son and I took an avalanche safety course, which is really aiming to equip us with the skills necessary to avoid getting buried in snow when wandering around in the backcountry, which might be a bit of a foreign concept to our colleagues in Nigeria, but bear with me. The instructors took us into the backcountry and introduced a number of complicated concepts, like how the variables of wind and energy and precipitation plays out in the dynamics of snowpack and avalanche risk. But they did so by focusing on the things that we could see and hear and touch. We measured slope angle, and we looked at the snow hanging in trees, and then we dug a big pit and examined how these little snow crystals that had fallen months ago to check out their relative size and how these layers of snow settle and impact the risk of avalanche. So it's how these snowflakes that fell months ago come together and bond or don't that determine the relative risk of an avalanche. And it struck me in that aha moment how the experience was very different to how we typically introduce a complicated topic like a market development approach, where a number of challenging concepts are introduced, couched in even more complicated frameworks and diagrams, and rarely do we get the tangible elements of program design that reflect the actual activities that underpin the concept. So today we get to look at the snowflakes. This is where it comes together. The composite parts that comprise a market development approach. The lineup of presentations today illustrate the how market development gets implemented. And specifically, we can work to understand how these discrete projects can bond together to give market development a chance to improve the entire health system, when dozens and maybe hundreds of interventions can be understood as contributing to a whole and improving the health of many. So I wanted to thank Andrea and Cynthia and those that brought together all of these great projects to illustrate what a market development approach really is. So finally, let's go to the next slide, please. Because we can't completely avoid concepts, let's just touch briefly on a few that underpin a market development approach to understand why we're here today and how a market development or systems approach differs from traditional health interventions. So Many of you have seen versions of this slide, which I still think is fun and helps to bridge the gap from MDA as concept to our lived experience. So the section on the left depicts a guy chasing a fire and a fire breaking out. And while we can put the fire out, we're just chasing fires. Nothing's been done to prevent new fires, and we're only dealing with the symptoms of a very big problem, particularly if the fire is your house. Moving to the middle box, we study where the fires break out and locate more fire stations in areas that have more fires. We can adapt to the data, but we still haven't done anything to prevent new fires. We're just dealing with fires more efficiently, still chasing symptoms. And moving to the far right, which is a little hard to see, if we do work to understand what's causing the fires and invested in preventing fires in the first place, we're starting to think about systems. And systems can lead us to long-term fixes that include, in this case, what happens when we look at the availability and use of smoke detectors and fire alarms and placing extinguishers in buildings convenient so that small fires can be put out before they get to be large fires. And they include development of regulations to improve building codes and ensure the availability and use of fire-resistant materials and better building practices. So identifying the root causes of market system failure and designing practical solutions to address those root causes is what a market development approach is all about. Let's understand what's causing the fire rather than chasing the fire itself. And this is also how a market development approach challenges us, that the skills and resources required to put out fires are much different than what's needed to ensure we've got solid policy, our regulations, our education, our financing, or information in place. But that's why we're here in this community of practice to learn and share. So if we go to the next slide, please. So let's spend a second talking about why we're talking about an MDA. So we all recognize that as donor resources are on the decline, and as the health markets, they support mature, and the private sector becomes more engaged, more vibrant than ever in the provision of healthcare, we need a new strategy to deliver on health programs. So an MDA promises three core things. One is scale through systemic fixes that focus on improving performance and the reach of the entire health system, rather than directly delivering care more efficiently. Second, because those fixes address the underlying root cause of programmatic failure and continue long after the intervention is ended, there's a promise that the health system is improved and therefore sustainable. And finally, we're also looking for long-term health impact, which is possible through greater sustainable reach of markets. So, ultimately, all of us here are because of that long-term health impact objective. So next slide, please. Some core characteristics of an MDA. I just want to touch on three things here in the interest of time. One is it takes time, years, to evolve a market. And so it's important to be patient. Any intervention that addresses an underlying root cause is not going to have the immediate impact that delivery has. So for all of the donor in the rooms, it takes time, slow down, and let's wait and ensure that these interventions have time to play out, ultimately to impact the way that the market functions. Secondly, partnerships matter a lot. There's no one organization or entity that can perform all of these functions that we're going to talk about today. And that's why it's great to have this community of practice here together to understand these different approaches are required to deliver sustained change. And finally, government ownership and ultimately stewardship is critical to this, making sure that we've got one focal point in the room to coordinate some of this work ensures lasting change. So let's go to the next slide, please. Real quickly, the essential elements of a market development approach include this process to support it, includes starting with the user and understanding who the market is failing and what's driving that market failure. We need to understand and diagnose how the market is failing to address those user needs. And that can take place through building an appropriate time for market analysis. Third, we ensure that once we understand the market, we understand the underlying root causes of those failures. And finally, and only then do we begin to design interventions to address those root causes. So you'll see a variety of approaches being used throughout the practice, but they generally follow these four elements in design. Next slide, please.
About 2 minutes, Chris. About 2 minutes, Chris.
Okay, thanks. So a number of approaches and supporting frameworks exist to help us understand the market, which is a critical component of MDA. I just want to flag this to highlight that resources do exist and are growing. Most of them are built around specific use cases. I'm not going to go into any of them specifically, but some are better at doing some things than others. So I'll focus there. Let's go to the next slide, please. So what we're looking at here is an overarching framework that I think does a great job to describe a health market, which was developed by the Springfield Center and evolved for health markets under the leadership of Barbara O'Hanlon. In the middle, we have the core supply chain working from manufacturers to consumers. And then on the outer edge of this is the supporting functions, which include financing and partnerships and coordination. So if we go to the next slide, we're going to go rapidly through a number of these and begin to tie in the intervention. So understanding and analysis and information is critically important to a market development approach. So Dr. Dada, representing SEMA, and Stephanie from Palladium will share how assessments are used to understand the private sector landscape and all of those elements and underlying functions that comprise a market. We go to the next slide. Around financing, Solina will share how they are aiding the finance function through strategic purchasing of FP services, and Sunny and Onyeka of IHP will share how they're tapping into private funds to finance healthcare. Next slide. Provision of information is also very important. So Salient will share how they're facilitating a smooth flow of products and services through the value chain. And my friend Ben Bellows from Nivi will highlight how they're leveraging AI to facilitate a marketplace to connect and serve customers. Next slide. Around regulatory and licensing, which is an important function. Another project from IHP will share how they are enabling online registration of pharmacies to support the regulatory functions. Next slide. And next slide. And leveraging the value chain, SFH and DKT and MSI will highlight how they are leveraging the private sector to improve the value to support access to SRH products. And we're looking at PPMVs and the role that they play in supporting this. So you can see how a variety of different projects are critically important and necessary to bring together comprehensively a market development approach, different organizations, approaches to address the underlying function. So looking forward to hearing how these elements come together to achieve our objectives. So thanks.
Thanks so much, Chris. So Chris has laid out and woven in for you how these presentations will contribute to our understanding of the market development approach. And Isioma is going to join us to provide that context on the family planning markets in Nigeria. So thanks, Isioma. You have about 5 minutes. Over to you.
All right, thanks, Cynthia. My name is Isioma George. Good day, everyone. I'm an associate here at Solina. Like Cynthia mentioned, I'll be taking us briefly through the overview of the family planning markets in Nigeria. Next slide, please. Next slide. Yeah, as we can all see here, Nigeria has an MCPR of 12%, and it's clear that there's inequity in the distribution of family planning services, with the northern region underperforming, when compared to the southern region. And with an unmet need of 67%, it is very clear that there is a demand there that is not being met. And just looking at the high out-of-pocket expenditure, it's quite clear that there are some barriers in access, especially in a country where 63% of its residents are poor. And looking at the health infrastructure, it's clear that the private sector has an opportunity to improve access to family planning. Next slide, please. Yeah, so just looking at this, it's very clear that the demand for implants has increased over a period of time. And it's also very clear that the demand for implants is higher in younger women between the ages of 15 and 24 years of age. Also, there's been a growth in the use of long-acting reversible contraceptive methods over time, and that is something that we like to see. So it's also clear that there's been a shrinking in the demand for contraceptives within the private sector, although that potential exists. So there's obviously a lot of there's a need for investment within the private sector to ensure that that need is met within the private sector. Next slide, please. So just looking at this, what jumps at us is that the private sector has a huge potential, like I mentioned, to improve access to family planning. The tax sharing policy in Nigeria presents a big opportunity for that to happen by upskilling the private sector to be able to deliver, and also ensuring that they leverage the reach of the private sector, especially the for-profit private sector, to increase access to family planning. Some of the challenges that exist within the private sector, like we can all see, as gross migration of the health workers out of the country, some gaps in capacity to administer the long-acting methods, as well as the low profit margin that is associated with the provision of family planning services. So I know that this is a very brief update on the family planning markets, but I hope that this helps us to set the stage for the conversation. I know we have a lot of family planning experts on this call, and I'm looking forward to the questions and the comments and the other sections that follow. Thank you so much, everyone.
Thanks, Isioma, and thanks to Solina for pulling together that summary of the FP context in Nigeria so quickly. We'll try and provide a context for the markets we're talking about each month. So if there are different data that help you understand the market, let us know and we'll try and find a way to pull them together. Please do put that in the chat. But we're going to move now into these rapid summaries section of our meeting today. The first summaries will be short 2 minutes presentations around a resource or a tool or a quick update. And for presenters, let us know how to move your slides forward. And Liz will have her camera on and we'll let you know when you've got about 30 seconds till the end. And then we'll move into the second part of our rapid summaries, which will be longer summaries that go into practices and approaches, and we'll have about 5 minutes each for all of those. In the future, we will have lead time for more ad hoc updates from programs. But in lieu of that, today, just ask for you to put them in the chat and in the summary. We can include those in the notes to share within this community, make it a nice resource for people. And a last point, which is please do keep in mind, if there's any particular topic of interest that you hear today, that you feel like a separate or more in-depth meeting might be beneficial, we are happy to facilitate and organize that. So keep a listen for that, and we'll give you space to answer at the end. So I'm going to hand it over to Remy from Salient.
Thank you very much, Cynthia. Pleasure to be with you all. Thank you to USAID and UNFPA for backing this. So at Salient, what we try to do, just given how Chris explained the vastness of the pieces that make together the opportunities for the market development approach, we try to create a platform that synthesizes the very diverse information, especially on innovators who are deploying technology solutions to advance access to these markets by way of products or by way of services. And so in the next slide, it just shows our approach that we believe that the local in-market presence helps to ensure we're really close to the understanding, and by also having a dispersed distribution where some of us are also in North America, it helps to engage with the global actors in the North. And so the key things we act through in the next slide are built on the market intelligence that is at the core of our work. So by tracking these innovations on an ongoing basis through some work that Cynthia was involved with in the past together with Mara, we create that, constant trend tracking of what the evolutions are. And this we help to synthesize in reports that we release annually. The next one for the market intelligence will be out in the summer. And it includes recommendations that are very specific to what can be done to improve these markets, to help grow these markets. And therefore, we invite you to take a look at some of them, like the investing in innovation. And the current one we're working on now is online pharmacy regulation, something that will be cross-cutting and help to improve access to these markets. In terms of the trend, you'll see on the next slide, which is on the deck, just the kind of diversity that occurs and the fact that many of these innovators are playing across multiple platforms, either to providers or to consumers, to solve these access problems to products and services. Thank you. Very efficient placard.
Thanks, Remy. So we call on Palladium next, please. Ademola. Oh, sorry, IHP, sorry. Yeah.
Yeah, good afternoon, everyone. This is Dr. Ademola Serrano, please. And we're just going to talk about the Health Facility Regulation e-portal. Next slide, where we are trying to move the regulation of health facilities from a manual process or paper-based process into a digital process with all the attendant advantages. So in doing that, we're trying to build the capacity of the state regulators. The states in Nigeria are sub-national units here. We're trying to build their capacity. We're also trying to increase the engagement between both the state regulator, which is a public health regulator, to the private facilities that they're supposed to be regulating. We're increasing the transparency and accountability of financial flows. As the private health facilities pay monies to the state regulator, we want to see those monies and see what they are used for. And finally, of course, we are improving the data analysis capacity of the states, as well as using that data to make better decisions. A little bit of context in what we're trying to do is that in Nigeria, states are responsible for the health of their citizens, not the national body in this case. So usually you have a very, very, very different set of laws, different rules, different structures, and different capacities in each of the states. Now we're working in 4 states in the northern part of Nigeria, and we have to consider that a lot of their processes for regulation are undocumented or undeveloped. So we used an agile development process to engage with them iteratively over and over and over again. Challenges that we faced for this portal was, of course, difficulty in engagement across 4 states, and we just had to continue pushing on and on and on. Other challenges that we faced was they wanted to increase the project scope. The project scope was to focus on private health facilities, but now we're asked to do public health facilities, regulate them. We were asked to do pharmacies and PPMVs. Okay, how's this stuff now? But just to the impact that we're looking at, because I think that's very important, is the data insights. That's extremely important for what we're getting. We're going to know the health infrastructure in all the states. We're going to know, for example, the SRH infrastructure, the family planning infrastructure, and that's going to help improve the health quality also, as well as the collaboration, like I mentioned, between the public and private health parts of the state. So thank you very much.
Thanks, Ademola. So call on Society for Family Health. DK. Oh, sorry. We call on, excuse me, DKT next.
Okay, good afternoon, everyone. My name is Kola Uluwabi, the Sales Director of DKT. I will be speaking briefly on leveraging digital technology to improve the accessibility of SRH products in the private sector and hard-to-reach regions in Nigeria. For DKT, we decided to, in order to have a quick accessibility to our customers in private sectors, we decided to adopt a CRM called Telenet in order for us to be able to have a relationship with each of our providers, and through different channels that we cover currently. We cover the PPMVs, the pharmacy outlets, the hospitals and clinics and maternity homes, and other channels. So what we are trying to do with the use of CRM is to be able to have the customer data, to have the name of the outlet, the address, their contact, and in such a way that we'll be able to keep track of their purchases and the history of what they are buying from us. So that is one of the things that the CRM has achieved for us. And also, it also helps us to come in contact in terms of lead generation to prospect some customers, even though they are not buying from us at a particular given point in time, but we have their database that these are potential customers. Then the CRM we are using, the software we are using is actually customer relationship management. Then in terms of having users interface, we are able to track the activities of our reps in the field at a particular point in time, what they are doing in a particular outlet. This CRM enables us to see what they are doing in real time. We are able to see the activities of the customers. We are able to see history of such customers. In fact, in most of the cases, we'll be able to say, okay, this customer has bought OCP in 3 months. What is happening? Is it that the customers are not asking? So we are able to keep track of what the customers are buying at a particular point in time. Of course, in doing this, we will be able to carry out our sales activities by closing the sales, getting order from the customers, and the CRM also enable us to do some reporting, like the picture you are seeing beside my presentation now is a GIS map that shows clearly all the outlets that we are covering or we are selling to. And this tool also enables us to see gaps in a particular either territory or state or a local government, to see that there are outlets in these locations and that our reps are not covering. So we'll be able to ask questions around why is it that a particular outlet, either a pharmacy outlet or a PPMC, why they are not stocking our SRH products. So this enables us to see that. And as well, customer journey, we'll be able to track customer from the day of getting data from them and the progresses they have made in time past, in such a way that we'll be able to give history of a particular outlet to know what are the products they are currently carrying and how do we expand their product portfolio in terms of each of the outlets. So this is what the CRM has enabled us to do in time past. We started using the CRM since October 2015, and up to date, we are still using it. Currently on our database, we have over 11.
Thanks, Kola. I'll just ask you to wrap it up. It's so great to hear about this.
So the data of each of the channels that we have is actually attached to the presentation that I've just provided now. Thank you so much.
Yeah. Thanks, Kola. It is exciting to hear about the demand side of the getting data on the demand side so we can understand these markets better. It's always been a missing area. We will send out the slides after this call, but we're going to move now from those rapid fire summaries into slightly deeper dives of ongoing practice, approaches, and research. So about 5 minutes each for these presentations. I'm going to call on Society for Family Health, Dr. Anthony. Welcome. And yes, great to have you on camera while you're speaking. And do keep an eye on Liz for the timing. Thanks.
Oh, thank you very much. I'll try in 5 minutes to give out some of our flagship, interventions in the private sector. So for us in SFH, we believe in the bottom-up approach, and for us, partnership is one of our key differentiators, and the other key differentiator for us is our deep understanding of the private sector through research and our ability to, leverage on this knowledge, for public good. Our private sector strength is, focused on customers, efficiency, delivery, and accountability, and we feel very strongly this fits very strongly into our organizational ethos. So we do a lot in the private sector, but most importantly, I will highlight 3 projects, right? That we'll talk about today because of lack of time. The first is our intervention through the Momentum Private Healthcare Delivery Project. This is a private sector capacity building project. And this project has also helped us in the introduction of new product, which is the hormonal IUD. Also, we'll talk briefly about our work on Integrate project, which is into systems training, and then our social business enterprise. So for our work on the Momentum, the MPH, the Momentum Private Healthcare Delivery Project, most importantly, this project is funded by the USAID, and it seeks to strengthen the private providers' contribution to MNCH, FP, and RH. This project is assisting the total market introduction of hormonal IUD, like I've already mentioned, by supporting increased private sector supply of the product, and most importantly, the total marketing approach. So with Mirena as the premium product and the ICA donated foundation for the lower quintile, we have this project supporting through the production, making available Avibela, which is a mid-priced hormonal IUD product. And then this project, in the project, we leveraged on a previous project, the R4S LEAP project, that developed a digital curriculum for training of private providers. So the MPH project has trained providers using this digital curriculum to train providers on hormonal IUD, and this is a course that was domiciled on the Kaya platform. Also, part of this is the demand generation part, which tend to increase, build the capacity of community mobilizers, and radically change user knowledge and motivation for hormonal IUD. So in this project, we've trained 54 interpersonal community IPC agents, and this has been done in 9 states. Also achieved on this project is the training of 122 family planning providers, both in the SFH Healthy Family Network and non-network providers in these 9 states. They've completed the digital training, and then because it's a hybrid, ongoing is the clinical supervision practicum for these providers. So the next project I'll talk about is the work we do on the Integrate project. So the Integrate project is actually a systems training project where we work with community pharmacists as well as drug stores, that's PPMVs, proprietary patent medicine vendors. So if you look at this slide, you will see our work in Lagos and Kaduna, and you'll see the GIS mapping of where the PPMVs and the pharmacists are located, and almost covering the whole of those states. But you can see that there are more pharmacists in Lagos and more PPMVs in Kaduna State. So the project has supported the inclusion of these pharmacists and PPMVs into the strategic framework for community health in Nigeria policy that was finalized in the year 2021 in terms of systems training. There's also supported the expansion of family planning service to the community pharmacists, also supporting PCN in digitalization operations, and of course supported the development of mobile DHIS for this cadre of healthcare providers to make sure that data is not lost. So finally, I'll talk about our SBE project, which is the social business enterprise. Yeah, so this is what we've done, in the SBE product, where we have interventions in malaria, maternal child, sexual health, water, and hygiene. But most importantly, before I go, I just want to talk about some of the work we've done using digital innovations. We have mentioned the Kaya platform. We have the medical learning hub, which we've used to also train providers in the private sector. And then there's, our digital companion on the DISC project, which has a geolocator and so on. So this is just to show some of the achievements from all this coming from the private sector. So because of time, I think I'll stop there since the slides will be shared. Thank you very much.
Thanks so much, Dr. Anthony. I know people will put comments in the chat, but I'll just call on Ben from Nivi up next.
Great. All right. Well, thank you. It was wonderful to join everybody today. Thank you for the opportunity. Ben Bellows, I'm the Chief Business Officer and one of the co-founders of Nivi. We've really developed this as a Nivi as a conversational marketplace to bring together consumers and providers. On the next slide, we think of providers in a marketplace, and we begin putting these providers into buckets or categories as a way to begin to organize our thinking and provide a holistic solution to solve for that marketplace. So we think of providers of health information as health educators. They could certainly be nonprofits, but it also could be the Office of Health Promotion in a ministry at the state or county level. There are certainly service providers that are providing products and services. But not only that, there are also financiers or payers, the various state level health insurance agencies that might be covering some of that out-of-pocket cost that would otherwise be incurred for particularly LARCs or other more expensive contraceptive methods. And there's certainly in the supply chain, manufacturers and others who are interested in what's happening on the consumer side. So on this marketplace, we have both providers of these various kinds and obviously consumers of products, of services, and of family planning information. In the middle, we see this opportunity then for Nivi to help foster connections in this marketplace between those providers and these consumers. We can do this through generating health awareness. We can do this through promoting uptake or removing barriers to the uptake and the continuation of products and services for family planning. And by, in the process of doing those two first steps, creating derivative data insights, anonymized, aggregated insights about the nature of consumer demand and those behaviors, providing additional value to help drive this forward beyond or complementary to grant-funded cycles, driving this forward more on a commercial basis, thinking about ways in which we can be proactive on an ongoing 24/7 basis for both the providers and the consumers in this marketplace. Next slide, please. The relevance then, the way in which we do that, the way in which we make this marketplace work is engaging consumers in what we like to call consumer journeys. And I've heard others already refer to that today. We talk about consumers being on a process, a learning process. For us, basing it in the sort of theoretical constructs of behavior change, we think about it moving from states of pre-contemplation or pre-awareness into some interesting moments of being of nascent awareness, of being activated by calls to action. And we do this through WhatsApp. So we have these calls to action on social media campaigns or with community health workers, bring people into a digital conversation through a chatbot, but doing that with an intent to motivate their action through theoretical constructs, again, behavior change, with referrals, reminders to take up those referrals and nudges to help follow through and adhere to a family planning objective. Is it taking up a method or continuing on a method? So next slide, please. We do this in partnership. We do this because it's a marketplace. We do this with many of you on this call today. We operate in 3 large national markets, but in Nigeria, we have onboarded more than 1,500 providers, largely PPNVs and CPs, with our strategic partnership with SFH, initially on the Integrate project, but working with others in this space, with FHI, with Pathfinder in Kaduna, and with digital partners like Health Plus and others in Conga to make available a wide range of relevant options to consumers so that they can complete their reproductive health, achieve their reproductive health goals. The idea is to provide essentially a level of attribution and verification that helps us support these user journeys throughout the life course of users so that they're being served their family planning needs today and maybe their maternal health needs tomorrow, or some of those other primary health concerns that SFH alluded to in the previous presentation. So I'm keen to hear more about the overall partnerships and the state of the family planning market. I think there's one other piece I'll plug in the last 30 seconds here, is the value of the insights that can be generated from this. And I noticed in that initial scoping of the FP space around DHS, for instance, that slide made it in. We're going to I'll quickly speak to that, sort of the conversion we see across the user journey. I didn't realize that slide made it in. Talking about new accounts created on a quarterly basis and then onboarded into the Nivi experience and onto redemptions. This is the basis by which we can generate insights on a very quick basis, thinking about a monthly or a quarterly basis, to determine the nature of demand dynamics. What sort of antecedent attitudes and behaviors can drive uptake or promote uptake and adherence to the family planning products that so many of you are engaged in supplying into the marketplace in Nigeria. So I'll stop there, Cynthia, but I just wanted to plant some seeds and hope to see some of the follow-up conversation going forward. Thank you.
Thanks, Ben. Well, Amina, just call on you to speak from Solina. Welcome.
Yeah, thank you so much, Cynthia. My name is Amina Babari. I'm an analyst working with Solina Center for International Development and Research. Next slide, please. I'll be taking us through the summary of findings from the PPMV's value proposition study, which we had done in July 2022. Next slide, please. So MSD for Mothers engaged CETA to conduct a detailed analysis of the PPMV's willingness to pay for and to adhere to PCN's accreditation program, as well as to develop a package of value-added benefits to drive increased demand for the program as integrity scales up. So we conducted desk reviews, qualitative and quantitative interviews, as well as an ideation workshop with relevant stakeholders to design tailored incentive structures to promote PPMV's participation on the PCN's debt accreditation program. And we surveyed a total of 375 PPMVs across the states that we can see on the right. So our outputs were 5, but we'll be focusing on the first 3, just running through the headlines. Next slide, please. So our most interesting finding was actually on the return on investment, where we found that most PPMVs stated that their revenue increased by 50 to 100% since they joined the accreditation program, and they attributed the revenue growth mostly to malaria and the second highest to family planning services. So interestingly, it showed that not only were the PPMVs providing these services, but they were also gaining an increased revenue from providing some of these family planning services. On the second finding, the incentive structure, we found that most of the PPMVs preferred access to loans and grants, as well as capacity building and branding as their most preferred incentives to join and to drive their participation in the program. On the willingness to pay, also interesting, most of the PPMVs were actually willing to pay for the accreditation. However, the amounts that they were willing to pay varied. We can see that as the amounts that we asked if they're willing to pay increased, their willingness to pay actually decreased. So those willing to pay for the enrollment fee are significantly more than those willing to pay for the enrollment and licensing fee, which was about 30,000. So just next slide, please. So just some key takeaways from the assessments. The study findings demonstrate that the accreditation model has contributed to increased revenues and client flows for the PPMVs, strengthening the business case for follow-on investments, which really validates the effectiveness of the accreditation program as a very good marketing approach to drive increased demand for family planning, to drive increased service delivery for family planning in the country. And we also found that incorporating PPMV's preferred incentive options like access to microcredits, such as loans and grants, access to commodities and branding holds potential to increase PPMV's participation on the accreditation program and also strengthen the provision of the critical family planning services. So from this, we can see that channeling investments towards testing and institutionalizing the priority incentives that we have found from the study as part of PCN's tier accreditation program will further strengthen the value proposition for PPMVs and contribute to already established sustainability efforts. So the third and final takeaway is really that the tiered accreditation continues to be resource intensive. It's mostly donor funded, and financial resource availability is really a limiting factor to scaling to more PPMVs across the country. Based on our study findings and the willingness to pay, it shows that a phased transition of costs to the PPMVs might be possible in the future. So exploring potential cost transition models and other cost reduction initiatives in the future will really increase PCN's scale-up efforts and contribute to already established sustainability initiatives. That's it from me. Thank you.
Amina, thank you so much. It continues to be exciting to hear about how accreditation is a way to organize the private sector. There are questions in the chat I invite you to answer, and possibly Dr. Anthony, I feel like you might be well positioned to answer the question from Jeff Barnes as well. So just Colin HSCL, great to have you online, Tolube, and over to you.
Okay, hi everyone, good afternoon. So my name is Tolu from Health Systems Consult Limited, Nigeria, and I'm who we are at HSCL. We are a health and development consulting firm, and we have established presence in Nigeria, Sierra Leone, Tanzania, and Zambia. And what we do is that we provide high quality solutions across a wide spectrum of interventions in the health and development space. So we do health financing, we do nutrition, monitoring, evaluation, and learning, research and management, among others. We actually do quite a lot. And our vision as a firm is to become a leading firm that provides sustainable development solutions in Africa. And our mission is to provide high impact and cost-effective technical assistance towards improving access to quality care and achieving sustainable development. Next slide, please. So I'll be talking to us on strategic purchasing for family planning and its implication for FP commodities market approach. Next slide. Next slide, please. Thank you. So I'll be speaking to us around our family planning work in Lagos State, Nigeria. So the program is called the Strategic Purchasing for Family Planning and MMCH project. It is supported by the Bill and Melinda Gates Foundation and implemented by a Health Systems Consult-led consortium. So it's actually a consortium of 4 partners, with HSCL being the lead partner. And the intervention was for us to support the state government in developing an evidence-based approach for integrating family planning and other MMCH services into the state's health insurance benefits package. So since the inception and the rollout of the state social health insurance scheme in Lagos State, it was founded that the benefits package, which basically contains the services that enrollees have access to, did not contain family planning. So it only had the family planning counseling in it, which meant that if an enrollee came for family planning services, they would only get counseled, but they would not get any services in terms of commodities. And if they wanted any commodity, they would have to pay for it out of pocket. And so the intervention was to actually come up with an evidence-based approach for the integration of family planning. And so the approach started from building consensus from all stakeholders through sensitization and advocacy. And stakeholders include the government agencies, especially Lagos State Health Management Agency, which is the agency that is in charge of implementing the state social health insurance scheme in the state. Also, the other agencies, PharmA, that is the Health Facility Accreditation and Monitoring Agency, which is in charge of ensuring that facilities in the state actually provide service at the expected level of standard and quality. And other stakeholders that were very vital also included the associations of providers in the state and other private organizations that are involved with service provision, health service provision. So we also did some provider readiness, getting facilities ready for empanelment into the health insurance scheme, and this required them providing service at the required standard. So we did some work with private providers, especially to ensure that they met the requirements to be empaneled on the scheme. Since we know that the benefit package is equally important, but the quality of the service the enrollees will be having access to is also very important. And the major thing that we also did was the conduct of an actuarial study. Remember that we said the intervention was to have an evidence-based approach. And so for us to have evidence, we needed to conduct an actuarial study, which would let us know if adding family planning to the existing health benefits package would require either the government or the enrollees to be paying additional fees, because already there was an established premium for the health insurance scheme. And since we wanted to add family planning, we had to know if addition of family planning would require them to pay more. And in the conduct of the actuarial studies, we did not do just for family planning. We actually went on to look at other vertical programs in the state. And this gave us the answer that we needed, because addition of family planning to the benefits package did not require anyone to pay more for the premium. So the premium remained at the amount that it was. Next slide, please. And so in the course of the integration and continuously what we're still doing, we're engaging private providers. Remember, I said we were doing some provider readiness. So we assessed the capacity of over 300 mid-level providers to provide HMCH services with a special focus on family planning. We're looking at the services they could provide. We're looking at availability of trained personnel and sources of the commodities. And so part of the work that we did was linkage with social marketers. For instance, we did some collaboration with DKT by linking these facilities with DKT, and about 24 of them actually signed partnership with DKT based on our intervention, while 98 signed for supply of commodities. And we know that this offers a lot more benefits to them because they are guaranteed discounted prices, quality, and some credit facilities, likewise free trainings and periodic on-the-job support. Next slide, please. Right, so now to the implication of the integration of the FP market. For commodity sourcing, already private providers in the States access their commodities from a couple of sources, including social marketers. I know my time is up. And next is the method of reimbursement. Reimbursement on the health insurance. Some are done by capitation, especially the injectables and pills, while there's a fee for service for IUDs and implants. And on service delivery, we believe that the reimbursement methods that are adopted actually allows for a mixed method, because now there's higher demand, because the enrollees that are already on the scheme know that they're not paying more for family planning, and so they can actually demand for the service when they go to the facilities. And so providers are encouraged to actually source more commodities and ensure that they do not go out of stock when enrollees actually demand for the services. Thank you very much, and thanks for listening.
Thanks, Tolu, for this. I mean, it's great to have this one presentation around health financing because it has such an influence on these markets. So we're going to call on Palladium, and we have a couple of different speakers in this session. So Stephanie, take it away. Guide you on the timing.
Yeah, I'll try to be quick. Hi, everyone. It's great to be with you. I'm Stephanie Gallagher. I'm a senior technical advisor for private sector engagement in Palladium's health practice. And as such, I support the Integrated Health Project in Nigeria. IHP is a $225 million bilateral contract working to improve access to RMNCH services, predominantly in the northern states. And that is done through policy financing, advocacy, and governance work, as well as support to service delivery. And that focuses on both the public, but also the private sectors, because of the large role the private sector plays in delivering care and treatment in Nigeria. So let's go to the next slide, please. So to get a better handle on how the private sector is delivering RMNCH services in the northern states in Nigeria, which is where this project focuses and started, there was a scant kind of market description and research available. So the project did start by implementing private sector landscape assessments in the 3 northern states of Bauchi, Kebbi, and Sokoto. That was done through a mixed method study design of quantitative and qualitative data through in-depth interviews and then facility surveys. This was successful, and we decided to do landscape assessments in the Federal Capital Territory last year, and then this year is planned for Ebonyi, but leveraging existing research and literature that's more available for those states. All those landscape assessments were then validated by a multi-sectoral stakeholder group. And this really speaks to the approach that was outlined by Chris in the market development slides around garnering local ownership for effective governance and stewardship. Let's go to the next slide, please. So in concert with the PSLAs, the landscape assessments, the project also did service availability mapping in the 3 northern states to get a better handle on where are all the different types of facilities, public and private, as well as community pharmacies and PPMVs. This could help inform strategies to reach those populations that are most underserved in those states, and where to focus efforts on improving service delivery, whether that be through training and mentoring, or if more improvements were also needed on the regulatory policy financing space. Next slide, please. So combining the findings from the PSLAs and the SAMs, we were able to work with the state ministries of health to develop private sector engagement strategies. So kind of the first ever state-led private sector engagement strategies, which are part of and inform state health development plans. And in so doing, we really were able to establish, or the project was able to establish, trust in a meaningful way between public sector regulators and private sector associations and providers. That trust is kind of operationalized in these strategies with an operational plan that also has an M&E component. And as a next step from those, we were able to develop costed implementation plans, right, to feed into the state budget, to get some of these initiatives and activities for trust building and strengthened governance funded beyond the life of the project. And then from there, activities along those operational plans have commenced. That has been revising regulatory frameworks, sometimes for the first time in 35 years, looking at private sector health facilities. It's also led to the development of the e-portal registration tool that Dr. Serrano spoke about earlier. And we have more activities planned in the coming weeks and months. And as I said, this is also now scaling up to FCT and EBONI as well. All the findings from these surveys are available upon request, so I'm happy to provide those to interested partners. And that concludes my talk about the policy and governance work, but I'm going to hand it over to my colleagues now to talk more about some of the financing work we've been able to do with private capital mobilization as well. Thank you.
So good afternoon, everyone. Sonny Olukule Phillips. Next slide, please. So we'll be talking about efforts at mobilizing additional resources from the private sector to address the funding gap in the PHC service delivery. So in alignment with the government, starting from the national level, the focus on primary health care revitalization, these were adopted at the various states that we're working with. And we've been supporting these efforts, working with the states to mobilize these additional resources from non-government entities within the state. So we've been doing extensive baseline assessment, which are available, just like Stephanie said, for as many that are interested in that space. To look and have an idea of what the current status of the health facilities are vis-a-vis the infrastructural setup, the equipment support, so that we can actually predict whether they'll be able to deliver quality service delivery. And so we, as part of many mechanisms in this private sector engagement, also are implementing the Adopt a PHC mechanism. And we've had a series of different layers, different levels of inputs that have also resulted in different results. Next slide, please. Okay, so this is just an example of the efforts and the impact it has made at the state. So we work intentionally with FCT, Kebbi, Sokoto, and Ebonyi State, as was said, and then also aligned with a private sector initiative called the Private Sector Health Alliance Network, which is also targeting high net worth individuals to mobilize, advancing the concept of Adopt a PHC, mobilizing resources for that, for PHC revitalization. So we, at the state level, we are collaborating with them, particularly at the state that we are supporting. And the outcome are clear, that is, we will be able to have nothing less than 30,000 people receiving care from revitalized, quality-focused health facilities. So we can, like we said earlier, we can share the concept note for as many that are interested. I'll call on Onyeka, my colleague, to present the next set of slides. Over.
Good afternoon, everyone. Thanks, Dr. Sonny. So in the F, my name is Onyeka Ojogu, and I'll be providing just a brief overview of how we've implemented the Adopt a PHC initiative in the FCT. We've, of course, worked very closely with established state structures, such as the private sector multi-sectorial team that we set up across each of our states. And we started by having roundtable discussions with private sector stakeholders just to get a sense of their interest in the initiative and also their expectations. And then this then informed the development of a concept note that now defined our approach to the implementation and also the roles and responsibilities of all stakeholders that will be involved in the implementation. But very interestingly, the concept note also provided some information on menu cards that defined interventions across each across PHCs. This was done based on, again, the request from our private sector stakeholders as to guide how their investments would take place in PHCs of interest. So we were able to design 2 menu cards that provides this information on where the government currently works, what form of support is being provided by IHP or other private sector stakeholders, and then other support that are now required. To ensure that our approach is a bit more systematic, we categorize the PHCs into 2, with the first PHCs being the PHCs in line with the Premier Calendar One Roof Initiative. That's 1 PHC per ward. These are PHCs where some form of interventions have started taking place, so when we are in line with ensuring that at the end of any form of intervention in the PHCs, the PHC will be fully functional to be able to provide quality healthcare services. We also provided some indicative costs, but for transparency and accountability purposes, we advise interested private sector stakeholders to ensure that their costs are verified and they were responsible for the onboarding process of their contractors. So no funds goes directly to the government stakeholders. Next slide, please. So by implementing this initiative, we've been able to mobilize about just an estimate of slightly over 90 million naira across each of our states, with the highest being from Kebbi State. And majority of the contributions have come from organizations either in form of donations or renovations or payment of HRH salaries. And these have really helped to contribute to improving access to quality healthcare services. Thank you very much.
Thanks, Palladium team. I'm going to pass it on to MSION. Welcome, Moses.
Yeah, good afternoon, all, and thank you so much for the opportunity to present our work with private clinics.
Are you able to turn on your video, Moses, or we'd love to see you if so?
Yeah, can you see me now?
Perfect. Thanks so much.
Thank you so much. So, for over 10 years now, HMCoP Nigeria has worked to redefine quality sexual and reproductive health services, increasing access to quality and affordable SRH, focusing on client choice. Interestingly, as part of this mandate, we work with the private sector. And currently, as you can see on the map, this engagement is in 15 states, 12 in southern Nigeria, and 3 of them in the north, working with 142 private clinics. You can see some of the impacts of the work that we have done for the past 5 years, including provision of short-term methods, keeping to choice for our clients. If you look at some of the diagram by the left-hand side, that's actually an apt description of the model that HMCoP Nigeria currently operate. Why we work towards increasing provider cost contribution. We are very intentional in decreasing our cost of operation, so that ownership our work with the providers increase, we are seeing some level of increased engagement from these providers and trying to run that with a lower operational cost. The engagement is in line with our mandate to expand choice, as I mentioned earlier, and increase access to SRH services. We also work, interestingly, to expand product portfolio available for the private clinics, including medical equipment. Next slide, please. In the second slide, we intended to capture our journey in our private sector engagement work from the social franchising, as you can see, that was launched in September 2022, that franchised low and middle level clinic providers. We also see some level of work that we have done during the implementation of that model, trying to build the capacity of the providers and supporting the providers and the clinics on clinical quality. But in the whole of that model, some of the things that came back was there was less plan on sustainability. And, you know, it takes a lot of funding to keep some of the things we were doing, looking at that particular model that we ran for some times. If you look at the second column of what we have there, moving away from the social franchising to a new model of private sector engagement, we worked on a model that focused on sales and referrals to the clinics on SRH, while prioritizing, as I mentioned before, reducing operational costs and positioning the model for a sustainability pathway. Having done that, we have also seen some level of traction looking at the willingness of some of the providers we're engaging with to contribute to costs that to ensure that key activities within the models that achieve its purpose. Currently, and looking into the future, through the lens of the experience that we have gathered, we are looking at working on a different model that focuses on increasing market facilitation, leveraging on existing MSI competencies. Some of these competencies, as we all know, heavily on our training capacity, data collection support that we have given to these clinics and providers, and HMCoP's Nigeria robust knowledge on how to run a sustainable clinic and sustain choice to clients. We believe that the model would be a very effective and generate impact. But one thing that we're also seeing is that without subsidy, most of these programs struggle to reach the marginalized population and build a sustainability pathway that is robust for scalability. The next slide, please. Some of our takeaways, the learnings and the challenges. One of the key things there is consistency in data reporting from this supported side, even with some of the challenges that we saw. We also see that level of willingness that I mentioned before from these providers to contribute to the cost of trainings and make other contributions to ensure that some of the key things that we want to see work out in that model comes to fruition. However, when Mission stopped direct support to clinics on demand creation, we saw inadequate provider-led mobilization on SRH. It became an issue of which one do I give my attention more, looking at what the providers focuses on. We also see that as we work through this model, that there are some level of funding limitation that is also impinging on some of the sustainability initiatives that we would have loved to pursue. Because of time, I would like to stop here. And once again, Thank you for the opportunity to present.
Thanks, Moses. So it's great to hear about these, how MSIs approach services. We're going to move from services to products. Dr. Ebronike, we have speaking, I think, from SEMA on behalf of these the different organizations, PharmAccess, Halcyon. Anyways, I'll let you introduce yourself. Welcome. Oh, you're muted, my dear. There we go.
Good afternoon, everyone. My name is Ibiron Kedada. I'm the program director with PharmAccess Foundation and also the team lead on the SEMA SRH market assessment. I'll be sharing the preliminary findings on priority market shortcomings for 5 Nigerian states. Next slide. Chris Jones had already shared something about the framework developed by SEMA. It's really around assessing market health and country readiness, or the sub-national entity's readiness to manage its own market. So we tested this framework in 5 states in Nigeria, and across all states, no 2 states are the same. So we had varied results across all the states. We looked at market conditions, which are resilience, affordability, supply, demand, quality, and innovation. But we also looked at market foundations. These are the critical enablers: availability of data, institutional base, analytical tools, and partnerships. Next slide. So these are our summary findings on market conditions across the 5 states. In terms of resilience, we had scores ranging from 1 to 2 out of 5. All states rely on the Federal Ministry of Health's supply mechanism, and this was affected by the global supply shocks of COVID. So they had experienced quite a bit of stockouts at the time. There's limited fiscal space across all states. As of 2021, we had an estimated funding gap of over $10 million for family planning products. 2020 was the last year the government of Nigeria contributed to the family planning basket. There's a lack of local production of family planning commodities in Nigeria, and this was found as a priority market shortcoming for Lagos only. And stakeholders all felt that the existing pool procurement mechanism, the unfavorable investment climate, and the unpredictable demand would not make it a likely thing for private sector to engage in. In terms of affordability, we had scores ranging from 2 to 3, and that's as a result of the fact that family planning commodities are free in the public sector. All stakeholders felt this was unsustainable. There was limited insight into the private sector pricing and consumers' willingness to pay. Most payments in the private sector are out of pocket because we have low health insurance coverage. Public sector experienced stockouts, and we believe that these stockouts would, of course, drive up user costs because of multiple visits and the fact that clients have to purchase from the private sector. Private sector market is subsidized by the social marketers, and with markups ranging from 30% and below. In terms of supply, all states experienced stockouts. The average stockout for microgenome was 6 months, and for Depo-Provera subcutaneous formulation was about 3 months. Some NGOs were able to bridge this gap, for instance, in Ekiti State. There's limited data available on family planning demand, and in all states, private sector data is not used in quantifications. Public sector has challenges with last mile distribution, and that's, of course, due to funding gaps and bureaucracy. For demand, the score was 1 to 3. There's insufficient funding to meet family planning demand, especially in the public sector. We find that family planning demand is higher than supply. For method discontinuation due to stockout, Depo-Provera, the subcut, experienced quite a bit of stockout. For side effects, injectables had the highest discontinuation rates. For quality, the quality of products from the national supply chain is considered good. All states, with the exception of Lagos, have no capacity to conduct quality tests. Next slide, please. So looking at market foundations, we looked at a major challenge is the lack of data, total market data, and that was seen as a priority market shortcoming in all 5 states. Also looking at the institutional base that had a score of 1 to 3, government has a weak capacity for market stewardship and private sector engagement. There are no policies that reflect or include the private sector. Looking at analytical tools that had a score of 1 to 2, what we found are most analytical tools are limited in scope to assess the total market. Tools are siloed and largely analyze the public sector data. And there's limited capacity to utilize consumer insights and triangulate multiple data points for market development or improvements. For partnerships, there is no state level entity currently with the capacity to lead on new product introduction or market stewardship. Partnership is weak and a priority market shortcoming for all 5 states. And we feel that currently the way the states are structured, or the SRH market is structured, the private sector is large, heterogeneous, and highly fragmented. Private sector's role right now is undervalued, and there's really lack of incentives for private sector to effectively engage. Thank you.
Well done, SEMA team. Hopefully you all heard in that some of the tools and approaches that have been presented earlier can be used to address some of the gaps that the SEMA team has found. So it's pretty exciting. I'm going to, Liz, if we could just move forward a slide or two, pass it to Andrea for.
Yes, thank you so much. This just shows the power of community, I think. And so a huge thanks to every presenter and Cynthia for keeping us on track. And we only have 5 minutes to wrap up, so we will not have a full facilitated discussion. That said, we definitely would like to invite Ben Light to come off mute if Ben wants to share some reflections and comments. And then Cynthia and I have a question for everyone about the possibility of a follow-on Nigeria discussion, as well as future format. So Ben, would you like to come off mute and share any thoughts or questions?
Yes, thank you. Can you hear me?
We can. Over to you, Ben.
Perfect. Well, I'm pretty overwhelmed, I have to say. I found this incredibly rich. So, to everybody who presented, I'd really just like to, extend a huge congratulations. I think the breadth and the richness of what was presented was fabulous. I'm really inspired. I'm also a little worried of how do we capture this, because clearly 90 minutes is quite simply not enough. I found all of the presentations super interesting, and I was particularly struck by some particular things. The actuarial analysis that the FP had carried out struck me as super interesting, but I want to know more about all of it. And I think one of the things is that it's so important to look at the details in order for us at global level to be making smart policy recommendations. So again, thank you very much. What I was going to say, if we'd had a little bit more time, was about the broader sort of ecosystem for family planning and family planning financing. I'm not going to go into details about that. It's something I think we'll pick up in the future. But I think you all know that governments are increasingly required to use domestic resources to procure their products. Particularly, we've been talking about family planning, about contraceptives. And a key element of what we at global level are interested in considering is how we can work with you to stimulate the emergence of viable commercial markets. How can we tap into in-country spending? Currently, the donor model is to donate products. Increasingly, we're moving away from a simple donation model to a cost-sharing model. And I think actually that's going to change a lot of other things. We're almost out of time, so I'm going to hand back. But before I do that, I'd really like to give huge thanks to Cynthia, to Elizabeth, to Andrea, to Kuyosh, UNFPA. We are really thrilled to be carrying on our collaboration with USAID to further our collective understanding of how to move to ever healthier markets. And we're confident that the community of practice is going to make a contribution, a really important contribution in this area. So we're really looking forward to more and more of this. For the moment, back to you, Andrea.
Thank you so much, Ben. And now you can see on the slide, on the screen, but also in the chat, a question that we have for everyone, which is, obviously there's been a lot of great connections and some really good exchange already in the chat, but we are thinking about the possibility of a Nigeria-focused discussion. And so that obviously could be what is, up to the local participants and partners, their thoughts. And we're also really aware of the time required to prepare and participate. So we're conscious of that. We will also, if you don't have time to fully make comments in the chat, we will do some follow-up by email as well. And this is a community of practice, so everyone is welcome. And we also fully expect that while today's call was on Nigeria, there are learnings and sharings and application over to other countries and other markets. So with that, a huge thanks. Please, as you just wrap up, put any other comments in the chat. But again, going back to what Chris set the stage with at the beginning, I mean, we really covered, I think, the gamut of market development approach in terms of thinking supply, demand, the various supporting market functions. And a question I would have asked the group is, what might be missing? What might there be from a market intelligence standpoint, as an example, that various partners might want to see more capability for or resourcing for? So those are the types of questions that we want to facilitate as well. So with that, a huge thanks. More to come, and thanks again, everyone, for both presenters and participants. Have a great rest of your day, and we will be in touch. Thank you. If for anyone who wants to stay on an extra minute, I did see Dr. Olu, I think you had your hand up. All right. Yeah, feel free to reach out, and we'll address questions. And we are keeping the chat. We will know ideas and suggestions for countries. Thank you. Thanks, Cynthia. Thanks, everyone.